everyone. We are ready to get started with our webinar, Achieving Cardiovascular Excellence in an Evolving Landscape. Thank you all for joining. My name is Emily Dvorak, and I'll be facilitating our call today. So before we get started, just a few housekeeping items to run through. So first of all participants have been muted to maintain the integrity of the webinar discussion. If you have any questions throughout the webinar, we want to hear from you. Please submit your questions to the Q&A box, which is within your participant controls in your Zoom window. We will hold all questions until the end. We will likely answer your questions during our planned content today. So if we've already covered your question, I won't be asking it at the end. But if we haven't addressed it, we will have a Q&A portion to conclude the webinar, and I'll ask it then. So we're planning on having about 45 minutes of content today, followed by 15 minutes for Q&A. After the webinar, everyone who registered will receive a link to the recording so that you can watch it back anytime that you need to. And then we also ask that you please fill out our post-webinar survey to give us feedback on today's conversation. So without further ado, I'm happy to turn it over to our panelists who will introduce themselves, starting with Sarah DeMin.
Hello, everyone. As Emily said, my name is Sarah DeMin, and I have been a nurse almost 25 years. Within a year of graduating nursing school, I ended up in CCU, which is where I love to be more than any world, and just really enjoyed my time there. I did end up in management at some point during my nursing career and helped start an interventional program at a local facility, achieved chest pain center accreditation, and ended up over the cardiovascular service line director for the different areas in the hospital, including interventional radiology. I actually came to Q-Centrix 12 years ago. And for 8 of those 12 years, I worked in operations with our teams directly as they were working with our partners, and then transitioned to product marketing about 4 years ago, and just recently into the market lead role for cardiovascular. So really, really value the time that we're spending here with you today. Really appreciate the fact that you've chosen to give us this time, and really looking forward to the discussion today.
Hi, my name is Shauna Thornton. I am the Director of Client Services for the Cardiovascular Division. I have been with Q-Centrix for about 8 years and currently have oversight of all team members and partnerships within the division. We're composed of around 400 team members, each with cardiovascular expertise. We also oversee about 1,100 cardiovascular projects across approximately 500 hospitals. I'm an RN by background, with most of that time being spent within cardiovascular nursing, working both in and out of the hospital setting. I love working with others in the healthcare industry to elevate our standards for patient safety and quality of care. So I look forward to our discussion today and ensuring that we meet that need for patients.
Hi, everyone. My name is Sarah Devereaux. I'm a Senior Manager of Client Operations in our Cardiovascular Division. I've been in the field of cardiology and involved in cardiovascular data management for over 20 years, 8 of those with Q-Centrix. A particular area of interest for me is utilizing our data to drive process improvement and improve the delivery of care for cardiovascular patients overall. I currently support our CV programs for over 200 facilities across the U.S., and I manage the team of abstractors that help curate that data and report it to your hospital stakeholders. I also look forward to speaking with you all today and hope you find the discussion beneficial for your program.
So we want to start today off again, how we define cardiovascular excellence. So Q-Centrix is an organization that supports data collection through many different areas of the hospital: oncology, core measures, ortho, surgery, et cetera, lots of different areas. But what we have found is that the idea of excellence within the cardiovascular space is very unique and very powerful, and is a significant driver to organizations. And so as we prepared for this, we asked our participants to go ahead and weigh in on what they felt like was the best way to term cardiovascular excellence. So here's what you had to say. These are kind of a conglomeration of several different, we weren't able to include them all, but these were kind of the biggest and most resonating answers that we found. And so, of course, outcomes exceeding national benchmarks consistently, quality healthcare, heart healthcare at the very, very top and said over and over again. Keeping the patient at the center of the decision making, I think, is one of the most powerful statements that we received. And then having the necessary accreditations and expertise to see the majority of cardiac patients. I think the recognition of the need for a comprehensive cardiac program to best meet the needs of your patient population. So as you can see, there's lots of other answers here, but it's just a really fascinating idea. Again, something that's very specific and is a major driver within the cardiovascular space. I think one of the things to note is that the idea of cardiovascular excellence, as you can see, is a theme, but the way that we apply that idea to different facilities and their programs in a practical way is where the differences start. So whether you're a smaller program that's starting with interventional and maybe achieving chest pain accreditation for the first time, or whether you're a large heart facility that's been doing open heart and you're kind of beefing up the TVT and LAA offerings of your facility, cardiovascular excellence is something that we all strive for. So we spoke to one of our cardiovascular partners about this. Lehigh Valley Health Network is a 13 hospital health system based in Eastern Pennsylvania. And they recently announced an official merger with Jefferson Health. This make them one of the top 15 non-for-profit health systems in the US. So we partner with Lehigh for both data and technological services for multiple NCDR and STS registries, and we consider them to be an example of cardiovascular excellence. Mercedes Scott is the Director of Institute Planning and Program Management, and here is how Mercedes defined cardiovascular excellence.
So at the Lehigh Valley Heart and Vascular Institute, we define cardiovascular excellence by having a patient-centered approach where care is personalized and timely and coordinated, and where the focus is on both clinical outcomes and the overall patient experience. It requires a commitment to innovation and collaboration and accountability across all levels of care delivery. It is building a culture both within and outside of the walls of the hospitals that you serve, where everyone not only would recommend, but would require that their loved ones be treated by any provider in the system.
I think, again, highlighting that these are distinct ideas to cardiovascular, but also that they are applicable across the board, whether again you're a fledgling program or you're one where you're beginning to make those expansive steps. Cardiovascular excellence is something that can be achieved, again, so well put by Mercedes, and excited again for the opportunity to discuss that further with this group. So one of the things is that cardiovascular care is, as we're talking through this, it's an evolving landscape. There's lots of different things going on. There's lots of changes. And so how we address and how we achieve cardiovascular excellence, what are some, again, applicable steps, tangible things that we can do to ensure that cardiovascular excellence stays at the top of our priorities and the things that we're able to achieve. So you'll see here some of the things that we plan to discuss today. As Emily mentioned earlier, this is our content portion that we have planned, but also we have set aside 15 minutes at least at the end to be able to discuss any other things that come up that maybe we do not touch on. One of the other things we want to let you know straight up is that we are going to be talking about Q-Centrix services and some of the offerings that we do have in the cardiovascular space. Not because we want this to be a great big commercial, but we want to be able to talk about different solutions that have been identified and that we have found helpful. Because even if we are not the solution for your facility, we want you to be able to consider some of the solutions that we bring to the table and how you might be able to, again, apply those to your situation and the nuances within your system. So as we go, we're going to start with something that has been especially relevant since the pandemic. And that's the fact that many hospitals and health systems are facing labor shortages. So according to advisory board, there's actually projected to be a shortage of cardiologists by 2030, and that number is 120,000. So it's not insignificant in any way. The other thing is, again, the nursing shortage is something a bit, but we have not yet reached the peak of that. So the peak of the nursing shortage is not expected until 2027. And again, that's the peak and kind of the slow coming back down. So there's going to be effects from that for quite some time. So, Sarah, how have you seen this impact, our partners most recently?
Yes, we definitely know about labor challenges, right? I mean, both with the partners that we support as well as our own staff at Q-Centrix. So, as you can imagine, we saw the bulk of these shortages during the pandemic, and there was this major shift where hospital staffing became very lean, and nurses and other clinicians that were once in the quality space were being pulled from their quality roles and asked to serve at bedside as the facility census continued to increase during the pandemic times. So now in the post-COVID era, I think hospitals recognize the value of a clinical data partnership, maybe more so, where they can feel comforted to know that they have data registry experts in the role of abstracting so that they can reassign their nurses and clinicians elsewhere and back to the bedside to allow them to perform at the top of their licenses.
So you mentioned the post-COVID era, and I mean, we're living in that real time. And we've seen, I think, definitely a shift back to investing in quality. So we know that academic systems, facilities have always been invested in data. But definitely during COVID, we saw a focus towards meeting the immediate needs and kind of away from those non-essential quality pieces. But now we're seeing kind of a reprioritization, I think, of quality insights. So what comes to mind is recently there was kind of a large academic system that partnered with Q-Centrix for the collection of the EP device and implant registry. And I think it was across, 8 of their facilities. And so even though that registry is not required, I think they still are seeing the value of having those quality insights, even to the point of being willing to invest in them again. And so, Shauna, what are your thoughts kind of on this shift of quality focus?
You're right, Sarah. Data quality is continuing to become more important every day. After all, having a high quality data is the foundation for a successful journey to cardiovascular excellence. When you have unbiased data collection completed by a network of experts outside your organization, it helps to ensure that data quality. Not only that, but a clinical data partnership builds short and long-term value towards supporting your cardiovascular care and allowing internal resources to focus on the care of the patient and how your data can drive improvements in their care. Q-Centrix has been doing this for 14 years, and as I mentioned, we have 400 clinical data experts working on cardiovascular cases, many of whom are nurses with experience working in various areas of the hospital. We partner with almost 500 hospitals to support them through their cardiovascular excellence journey. So we're uniquely positioned to identify and share best practices that have helped partners to overcome barriers within their programs. This collaboration and knowledge sharing across the healthcare industry will help to elevate the care that our cardiovascular patients are receiving across the nation. But to complement this clinical expertise, it's important to have a variety of tools and reporting to assist in tracking and trending data. So here at Q-Centrix, we use our Q-Apps technology to strengthen our partnerships and provide clinical data quality insights to hospitals that can be used for continuous quality improvement. But using these tools and reporting, we can track quality performance throughout the year or quarter, depending on the submission, to know how a hospital is performing without having to wait for final submission or outcome reporting to be published by the registry.
Okay, so having insights before they're submitted, before the deadlines, before that quarter deadline comes, right? And you can't do anything about it. I think that's one of the things that you're really focusing on. And it reminds me of a solution that we did develop because we had so many partners ask us questions. And I think one of the main things about Q-Centrix, and again, whether it's Q-Centrix or someone, but it's an extension of your quality team. So there's a lot of ways that you can check the data box, but to have an extension of your quality team and in a way that communicates kind of on this ongoing basis with the facility quality team so that you can affect those outcomes in real time. So exception reporting, I think, comes to mind for sure because it's such a great example of the team of experts that we do have and their passion and their ability to identify opportunities, even down to like missing documentation opportunities. document that in the tool, send it over to the facility quality team. The quality team is then able to look at that and navigate it. Quality leadership is able to kind of pull reports off of it and see what trends are there so that those can be addressed. And that becomes, again, a really valuable tool to your point, because it's all completed before the registry submission. So I think that's a great tool in your toolbox to actually make that difference in your outcomes day by day. I think one of the other things that comes to mind is just trying to figure out which patients belong in the registry. So sometimes that day-to-day struggle is pretty significant. You know, what's the inclusion criteria? What's the exclusion criteria? And how can I make sure that all of the correct patients are in the appropriate registries? One of the things that Q-Centrix again developed through our partners and listening to them was the automatic case upload tool. And so through Interface, we're able to work with our partners and actually complete a lot of that work on their behalf. Again, the goal being to alleviate that day-to-day pressure of the data so that they can go focus on those process improvement projects, and then, you know, talking with their coworkers and getting kind of everyone on the same page towards that idea of cardiovascular excellence. So, Sarah, what are your thoughts on the impact of, you know, technology helping our partners?
Yeah, I mean, you just touched on it really. So here again, I think it's the mix between unbiased data collection by experienced registry experts and the use of technology really create this ideal situation or a perfect storm, right, if you will. So that hospitals can turn their attention to identifying areas within their facility where they can improve the care that's being delivered rather than the burden of worrying about if the data is accurate. So the combination of our expertise coupled with technology really allows facilities to use the tools that they need to get that big picture of how they measure against national benchmarks, which is what their main focus should be. So without one or the other, you really aren't equipped, I think, with the tools that are necessary to drive towards those internal improvements.
That's a great point. So we've kind of talked about the labor challenges and different ways to maybe mitigate, you know, the challenges that brings to the cardiovascular space, how to continue to drive for excellence. And now we really want to present a poll and understand what other challenges you are facing in your market and in your day-to-day. So hopefully you'll be able to take a few minutes and just answer what has been your biggest challenge this year.
Okay, the poll has been launched. Hopefully you're all seeing it on your screens. It looks like some early results are coming in. More results trickling in. We will leave it open for just about 15 seconds more. Allow everyone some time to respond. Thank you all for providing your input. Okay, it looks like we have a clear winner, and I don't see many more responses coming through, so I'm going to end the poll. And you can see that workforce challenges is actually the most commonly experienced answer for this group. So thank you all for that input. That's, you know, great confirmation of what you're facing, and hopefully that last section of our conversation, you know, helped to address your concerns. I don't know if Sarah, if you have any additional commentary on that. We also can take additional questions. If anyone has them, please submit them to the Q&A so that we can speak to them later on.
I think some of the challenges in the workforce, from my experience, is that everyone ends up wearing a couple of different hats. And one of the things that we'll touch on later, you know, is the importance of having kind of that, again, as Sarah mentioned previously, like this unbiased data collection and why that matters, because it's really easy to solution kind of some of those workforce challenges by saying, okay, well, this person who's on call or recovering this patient in the cath lab can also do my CV cardiac registry collection. And we're going to talk about some of the risk that's associated, you know, maybe with that challenge. But it's just it's a tough thing, and I think we're all in this together and just understanding again, is the extension, part of the extension of that quality team that Q-Centrix values most, enabling our partners to do what is most important, which is care for patients. We want you guys to be able to have the best possible care, the every opportunity, the best data, driving specific actions towards the care of those patients. And we hope and strive to bring value in that space because we understand at the end of the day, that is the most important thing. One of the other things that you guys mentioned was the clinical registry requirements. That was one of the things that was on the poll. And we kind of want to shift at this point, to that topic and just talk about the challenge that is the cardiovascular registry space. And if you have been in this space for any length of time, it is a challenge because things are always evolving, things are always changing. And so typically in the industry, we find that there's a pretty significant update in the registries every 2 to 3 years, typically, depending on what's going on. And so, there's evolving treatment recommendations, but that have to be taken into account. And so we're appreciative of the registry staying so up to date, but it does create a difficult environment to manage. And again, going back to that workforce, how do you make sure that those individuals at your site are up to date on all of the registry changes and have kind of adjusted to all the many instructions that have been provided? So I think the constant need to update registry collection and stay current with treatment standards can be a challenge, obviously, but it's necessary to ensure that we're tracking and training the right data to impact care. So, Shauna, I would love you to kind of weigh in on this. What have you experienced on this topic?
Absolutely. It's something that all of us that participate in registry data collection must deal with. So the registries took a pause from any significant changes and regular updates during COVID. And now that we kind of have all that behind us, they've returned to evaluating and ensuring that they align with current guidelines. AFib is a great example of this. It's seen a huge increase post-COVID. And so NCDR's just recently updated the AFib ablation registry. They've added 40-something additional elements to the collection form, and then have also incorporated follow-ups as part of the data collection. Additionally, we're seeing treatment innovations and devices that are constantly changing, resulting in the need for additional registry updates and then changes to those inclusion criteria you spoke about earlier. Registries are continuing to add procedure types. So we just saw this with both STS, GTS, adding a couple new procedures as well as the VQI registry. So these dynamic changes require continuous technology updates and education to be able to stay current with those registry standards. Sarah, what other examples have you seen of registry changes?
Yeah, well, you touched on follow-up, Shauna, and I think that's where we're seeing a lot. They're becoming more standard across many CV registries as they start to look more closely at the periods of time actually after the principal procedure has been performed as a reflection of the quality of care that's provided during admission. So this is resulting in a rather high volume of follow-ups required for multiple CV registries and throughout various timeframes in the post-op setting. So not just that one isolated event any longer.
Well, Sarah, to that, like I know that we've had a lot of questions from partners. What is the benefit of participating in follow-ups? Because it requires a lot of investment on the facility side, not only to track down patients and document what is required by the registry, but also to simply go in and capture it and then submit it, et cetera. So what does the additional investment by an organization or facility result in for them?
Yeah, so again, we've seen this shift in the landscape of healthcare, really, to not only including the data on the care received during the admission, but again, the readmission rates, post-op outcomes, all of those, and then all of that's captured during follow-up abstraction. So much so that registries like the STS for adult cardiac surgery, general thoracic, even vascular surgery, have really embedded this star rating component associated with follow-up specifically. So the amount of readmissions or even post-op events is really a testament to how well patients do once they're discharged. If they return for follow-up appointments, they maintain their health status after being released, not even to mention how well they're being educated while they're in there about their condition and health status. So to best capture these outcomes, Q-Centrix does a lot of work helping partners navigate follow-ups, and we've helped partners achieve success within these requirements. Do you have anything to add to that, Shauna?
Yeah, in addition to follow-ups, we're seeing additional registries being developed to align with some of these changes that we're seeing. For example, NCDR just recently introduced the new Outpatient CV Ambulatory Surgery Centers, or ASC Registry Suite. And this registry focuses on data and quality outcomes for the patient receiving cardiovascular services in a non-hospital setting. So now we're starting to see a shift to not only ensuring that patients are receiving the right care at the right time, but now also in the right setting.
So I think as we talk about the outpatient setting, I know that wasn't a big point of concern in our poll, but it's very interesting to kind of watch the market as things absolutely shift into that outpatient setting. So one of the things, cardiovascular has experienced and enjoyed kind of a stability of some of our core procedures, right? So EP, device and implant comes to mind, PCI. And I think the fact that NCDR has now registries to support the collection, of the different standards and guidelines in that space is a really important indicator to all of us in CV care. And so I just I think we want to make sure it's an opportunity for facilities to kind of look at both patient populations and ensure, again, that that standard of care is being provided, whether it's in the inpatient setting or whether it's in that ambulatory surgery center. So, Shauna, can you talk just a little bit more? Can we spend a little more time digging into the details of the registry?
Sure. So for those that have not had an opportunity to investigate the details, this registry provides care insights to the outpatient populations for diagnostic cath, PCI, EP device, and implant patients. The collection is very similar to the inpatient collection, but it ensures that the patient population and any respective risks for caring for the outpatient are considered separately. So by ensuring that you're providing excellent care, exceeding those benchmarks, and ensuring good patient outcomes, your program can be financially successful as well. Now looking at both outpatient and inpatient data. Participating in the CV ASC Registry Suite ensures a good foundation is laid for long-term success for your patients in that outpatient setting. We've seen a lot of buzz around this registry lately. And have had some opportunity to talk to partners, and we're excited to engage with them as they work toward excellence in all their care settings for their overall CV program. So our experience with cath PCI and EP allows this to be a seamless transition for the outpatient setting, and we're able to provide partners actionable insights using the tools such as exception reporting to impact their outcomes in almost real time.
I think it's interesting you mentioned financial success, and I want to spend just a minute talking about that because we all understand that the fiscal aspect of cardiovascular excellence ensures that cardiovascular programs are successful long term. And so that allows us to expand and to provide the most comprehensive care possible to the population we're serving. So although money is not why we do what we do, it becomes a really important tool for us to ensure that the care that we're providing, again, our patient population is the best care possible. And so I think the idea of that physical kind of responsibility is tied to a couple of areas. So if you even though most of the cardiovascular registries are not tied specifically to reimbursement, they intersect all over the place. So if you're looking at like the CMS CV aspects, there's several of those tied into the registries. Blue Cross Blue Shield allows a level of designation and therefore higher reimbursement. Tied to a couple of different NCDR registries. One of them that comes to mind immediately is Chest Pain Center accreditation and the overall defect-free care metric. And then if you're thinking about too, like Leapfrog, some of those. So there's all these ways that facilities have an opportunity to kind of really set that foundation in the outpatient setting that ensures quality, best outcomes, best patient care, consistent patient care, but also allows them to really impact kind of that long-term financial success that leads to that longevity and that cardiovascular excellence idea. So I think coming back to that is the idea of that unbiased data collection. So again, if you have an individual who is kind of self-taught or is perhaps coding in the facility's favor, that can lead you to assume or estimate that your outcomes are better. Maybe your reimbursement is going to be better than what it might actually turn out to be. And so we love our abstractors. We love, we work with so many of them, and the passion that they bring to data and the loyalty that they feel to their facilities is something like that I treasure. Clearly, it makes me smile. But at the same time, when it comes to data, when it comes to NCDR definitions, there has to be an unbiased aspect so that the programs can be managed, most effectively towards, again, that idea of excellence. And so it's just something that maybe needs to be considered, through the different things that we're talking about today. So Sarah, given our earlier discussion on data integrity, which is really what we're talking about, that data is meaningful, it's an accurate representation of the care that's being provided. Maybe share your thoughts on this for me.
Yeah, I think you really touched on it perfectly. I think regardless of whether you're focusing on an inpatient or an outpatient setting, quite frankly, the clinical data quality is so important because you want to improve your overall program and the overall delivery of care versus just that status or distinction, right? So it's really about delivery and consumer choice. And so when we talk about things like accreditation, these distinctions are public knowledge, and it's a way that facilities can communicate or display its dedication really towards their own cardiovascular excellence.
I think one of the tools that we talk about, in achieving that excellence is the idea of accreditations, right? And so I wanted to kind of shift, if we're good with that topic, and move towards accreditation and how impactful that is in cardiovascular. I think that it helps facilities guard community, again, going back to that patient choice, going back to the different things that are publicly available. And we also spoke to Mercedes Scott again about this topic at Lehigh Valley Health Network, and we would love to share with you kind of her thoughts on accreditation specifically.
So at Lehigh Valley Health Network, accreditations have been key milestones in our journey towards cardiovascular excellence. They serve as benchmarks for maintaining the highest standards of care, and they hold us accountable to rigorous guidelines and best practices. Achieving these requires us to demonstrate not only compliance, but also a sustained commitment to quality improvement and patient safety. Our clinical data plays a critical role in this process, as it provides the evidence needed to validate our performance and outcomes. Through meticulous data tracking and reporting, we've been able to showcase our achievements, identify gaps, and refine our strategies to meet and exceed accreditation requirements.
So Sarah, I know that you actually work with Mercedes, and so I would like to hear, your thoughts on what she shared.
Yeah, I mean, so many facilities that we work with rely on accreditation as a competitive differentiator for their sites. But like she said, due to its stringent requirements, accreditation, it really sets the bar and it helps establish quality standards for hospitals. I think it drives further expansion of their program to make improvements and make more options available to their patients. And a critical component to achieving the highest accreditation is to work collaboratively with your care team to use that clinical data. So like as Mercedes alluded to, it's really to be able to identify inefficiencies and ultimately drive towards internal process improvement. We have been fortunate enough to work with Mercedes and her team at Lehigh Valley Health Network to really dive into those areas where their cardiac programs were even falling a bit short. And we help them identify opportunities to not only improve, but really stand out among like competitors and like facilities in their area and on a national stage as well.
So I think there's so many accreditations and designations out there, right? So let's dive into that just for a minute. So the idea of all the many, many options out there and how you kind of determine which one is best for your facility to go after. So NCDR has absolutely, kind of really invested in this over the last couple of years. They have multiple different accreditations that can be achieved through their individual registry focus as well as kind of an overall comprehensive center. They also partner with Chest Pain Center Accreditation, which is a terrific exercise that facilities can go through to kind of ensure that everybody's working towards the same end with the care of chest pain patients. And then we're also seeing kind of a resurgence and again refocus on the TJC designations in their partnership with AHA. And I think one of the defining factors with several of these is that you can start with just the one, right? You can start with chest pain. You can start with the care of your cardiac heart attack patients. You can start small, which is still a big step. But I think there's so many ways now for programs to really build on that initial quality and that initial foundation of excellence and continue to expand. And that's what you see in the different forms of accreditation and designations that are there. So what we also have seen over the last year has been kind of a reinterest again in some of those more ancillary registries because their participation is required for several of these designations. So again, EP device and implant registry, TVT, LAO, AFib, some of these lead to, again, those more comprehensive designations. Um, I think the idea of accreditation, one of the most powerful things, and Mercedes said it, was that it drives excellence across the board. It's not just the cardiac program driving the cardiac program, but it's a dedication across the entire facility. And it gets those policies and procedures and a form of communication, kind of this ongoing process for the entire facility to get on board about the care of heart attack and chest pain patients towards the success of an entire CV program. So I think the data that is required to prove it, as she said, can be a really hefty kind of load. It can be one of those things that's like this overwhelming. I cannot do the data and do the policies and do the order sets and drive the meetings. And so again, that's where Q-Centrix considers ourselves a partner and an extension of that quality team that due to our expertise and the fact that we've done this forever, 14 years, that we're able to take on the data collection for those accreditations and those designations and allow our partners to do what they do best, which is drive that impact directly within the facility. So Sarah, we kind of touched on a lot of NCDR stuff, but what is some of the other public reporting that we're seeing impact our partners?
So one of the distinctions that hospitals receive that is publicly reported information that so many surgeons, facilities, perhaps some of the folks on the call here today even pay a lot of attention to is the star rating status for STS. And we know that these ratings have an impact on how your community perceives your quality of care and really the success of your program. So partners like Q-Centrix take that burden off of you, Sarah, as you mentioned, recognizing that whether you're a 1-star or a 3-star rated facility, this information's out there. It ultimately affects your reputation as a participating hospital. And we do our best to ensure that your data quality is accurate so that you can work towards these goals for your own internal improvement. Emily is sharing a slide right now, in fact, that it shows that even the best programs out there may be a 1 or 2-star site because it's awfully difficult to achieve a 3-star status. And as a partner, we've helped several facilities improve their star rating status with the STS. And what's important to remember is that these accreditations and star ratings are a direct reflection of not only the care delivery taking place within the facility, but the fact that what is being done is properly documented. And I always think about one example that comes to mind is a situation where we had a facility come to us that was named a 2-star rated STS hospital for adult cardiac surgery. And it was because their increased ventilation times post cardiac surgery reflected that 8.2% of their patients were intubated for greater than 24 hours post procedure. After our team worked with them to dig into the documentation, though, we discovered that their respiratory team was actually time stamping their extubation times as the time and day that they charted versus when the patient was actually extubated. So together we worked with them and their surgeons and care teams to create this template that the respiratory team would document that the actual date and time of extubation so that it was irrelevant of when that document was actually uploaded to the and so the real time stamp was actually there. So this whole process decreased the facility's prolonged ventilation metric by 55%. So it earned them a 3-star rating because then they fell into the national average at that point. Just really investigating the root cause is all that it boiled down to. So I think the takeaway here is that the documentation is just as important as what's actually happening. And this applies to all registries, not just for the STS.
So I think in keeping these top of mind, one thing that's really important is you kind of have to pick an area, right? Like when you're looking at all of the star ratings, you cannot address every single aspect of what feeds into a star rating all at one time. It's really important to kind of tailor your data to your collection tool, or sorry, to your goals, to your facility goals and your quality. So Shauna, can you talk a little bit more about that?
So to help our partners meet their goals, like you said, we can tailor our data collection based on what the partner wants to work on. So we developed enhanced insights specifically for the STS registry, where partners can elect to capture fields that were identified by our clinical data experts to impact metrics that'll drive that star rating forward. So enhanced insights goes beyond just registry collection so that partners can really just dive into their facility processes that need to be improved, like the example that Sarah gave with the excavation times. So we provide our partners with facility-specific data in a targeted and expedited manner. And this is really how a facility starts to make progress towards optimal quality care. Partners are able to efficiently track their metrics and trends to identify areas where they need to make improvements, and then use that data to really drive the action plans and the projects for the hospital.
So taking all of the things that we've talked about up to this point into consideration, and we've covered a lot, what's next for cardiovascular? And we'd really like your input. So this is going to be our final poll. What initiatives are most important to your cardiovascular program?
Okay, the poll is launched. We'll leave this open for just about 45 seconds or so. As we look to the future of cardiovascular, we certainly want your input, and this question centers around that. So we appreciate your feedback. Seeing results come in. We'll leave this open for just about another 10 seconds or so. Thank you all for your participation. Okay, we're going to close out the poll here. Looks like we have the bulk of responses in. And so it looks like the results show that quality improvement is the leading, initiative for this group as we look to the future, though certainly all of the choices have been selected by at least someone on this call. So we'll have some closing remarks about that and the future of cardiovascular in just a moment. And to kick off that sentiment, we have one final clip from our conversation with Lehigh Valley Health Network that we'd like to share with you all.
Quality doesn't ever end. It is an ongoing process. It is a culture that is bred into our network, and it is something that lives within us at all times. So I see our continued growth in the cardiovascular realm in more registries and more accreditations and better ways to leverage that data is where Q-Centrix comes into play, making sure that we can really show who we are as a network and what we do every single day. It's not just that leader that everyone has worked for that says that we have the most complex cases and we do the hardest things and we have the best outcomes. It is being able to say, here's a piece of paper that shows that we do this and we do it well. That is our commitment that we strive for every single day. And as technology changes and more comes to the front in the cardiovascular world, that's where we'll be, right next to Q-Centrix.
So again, it's interesting quality. That was the thing that all of you stated, or the majority of you stated was the most important and the most challenging thing. Merced is clearly, resonating with her, and quality never ends. And I think again, the reason quality never ends is because if for a moment we kind of back off of it, or we don't think about the registry updates, it absolutely trickles down and affects the care of that patient. And so quality ultimately is just another form of patient care. I think it's our goal at Q-Centrix to help you wherever you are in that journey and whatever way you need us. And we've highlighted a lot of different things, that we bring to the table as an offering. But again, the thing that we that we strive to be more than anything is an extension of your team and to become your partner in achieving those goals. And so whatever your next step is, as we've talked today, there are so many challenges that each of you are facing in this area. And we now want to kind of move away from everything that we've covered and then talk more about your questions, as we promised. We have about 15 minutes. So I think Emily is going to begin to share some of the Q&A, and we will do our best to navigate those with you. And so Emily, I'm going to hand it back over to you for now.
Thanks, Sarah. So I think we'll start with this one. And Shauna, I'll direct this to you. It's a two-part question. What are the priority metrics for a successful CV service line that leaders should focus on to assess their progress and prioritize areas for improvement? And the second part is, what are the best practices and tools for tracking these metrics?
Yeah. So I think this really depends on where you're at in your journey and your cardiovascular quality program. But for any program, a good place to start is with the metrics that the registry identifies on either their executive dashboards or publicly reported metrics. So start at a very high level and identify if you're meeting those metrics. Some of the things that come to mind are, Sarah discussed the STAR metrics for STS. PCI, things like STEMI treatment times, appropriate use criteria, avoidable bleeding complications are all important. The TVT registry has the 30-day morbidity and mortality composite. So that uses mortality and then complications within their risk-based calculations. It also looks at other variables such as KCCQs and 5-meter walk tests. So those are all good places to start depending on the registries that you're participating in. You can have a discussion with our data experts. They could also help you to identify areas to focus on for your continued quality improvement. But I think as you start to make any progress towards these and have solid processes in place, and then you can start to dig a little deeper into additional metrics where you have the opportunity within your program to tailor it to your needs. It's an ever-evolving process of identifying opportunities, developing process improvement plans and quality initiatives, and then going back and reevaluating your successes, and then identifying any areas where you can continue to improve your program. I think throughout this webinar, we've discussed several of the tools that can be available to you to track and trend these items. So for us, some of those tools are exception reporting and enhanced insights at Q-Centrix, but really utilizing the reporting that's provided by your vendor tools such as QApps.
Thanks, Shauna. I think shifting gears a little bit here, Sarah Devereaux, you touched on the fluidity of registry updates and the growing emphasis on follow-ups. Could you share some practical strategies you employ that might assist program leaders to stay current with these changes and ensure their teams adapt effectively?
Yeah, so a lot of what we see related to follow-up specifically is that the documentation of patients following up at either their primary care offices or even off-site surgeon offices don't make its way to the medical record. So it sounds pretty simple, but really just getting the documentation to the legal EMR is really the key to improving the numbers. So another suggestion that we have shared with facilities is to implement some sort of strategy for tracking patients in the post-op setting so that someone is responsible for ensuring that that post-op appointment is made, or at the very least, even making a phone call to the patient to check in, and that's documented in the medical record too. So really just identifying that person to take the lead internally at the facility level is really the key to ensuring that everything is captured no matter where it's happening.
Makes sense. Thank you, Sarah. Okay, I think that Sarah Demin, you touched on this a little bit already, but maybe we can dive into a little bit further. What are the most strategic actions that programs should take to achieve and maintain accreditations in an evolving landscape? And, how can programs get started with accreditation?
So I think accreditation is, again, a powerful tool towards long-term success for any cardiovascular program, no matter where you're at. And the reason for that, again, is that it goes beyond just the immediate cardiovascular impact area of the cardiovascular departments, and it spreads throughout the rest of the hospital and it gets everybody on the same page. Policies, procedures, order sets, all of those things that allow the clinicians to work at the highest standard and recommendation of cardiovascular care. So the trick is, again, like, which one do you go for? And I think that comes down to what your goals are as a facility. If you are just getting started and you are just new to interventional, or maybe you're going interventional within the next year, absolutely think about cath PCI within the NCDR, but also potentially chest pain center accreditation. There's a couple of things that that's going to do. It's going to potentially help you. Small facilities sometimes experience a bias. I'm going to go 15 minutes farther up the road or 30 minutes farther down the road to the big heart hospital rather than stopping at my own local facility. And so, again, those accreditations become really important to begin to shift your community perception of who you are. So chest pain center accreditation is a great way to, again, just get everyone aligned and lay a foundation of excellence in care from the very beginning. The other designations, there's heart attack designation again through TJC. Look where you're going. What do you want to be doing in the next 3 to 5 years? And look at those accreditations. What are the building blocks? Where do you want to add a procedure that you're not doing right now? Do you want to break out into EP? Do you want to potentially go again, LAO and TVT, structural heart is one of the areas in cardiovascular market that's projected to increase and grow. So do you want to get ahead of that? Look at the accreditations and the designations associated with that. Don't just think about what you have in place now, think about where you want to be. And then luckily, like I said, there are lots of options. So which one is the most doable for you? Which one is the one where you feel like, if I'm going to get everyone around the table and we're going to spend this amount of time and money, what do I want to achieve at the end of it? And the designation that best suits. Google, go to the TJC. They've got the number of heart attack, different designations for heart care hospitals, and then also for the NCDR, and take a look at their designations as well.
Thank you, Sarah. I think so. This next one, it circles back to our conversation around outpatient care. And Sarah Devereaux, I'll direct it to you. Since the population is shifting to outpatient care, what additional steps can programs take to maintain data quality and collaboration between inpatient and outpatient settings?
That's a good one. So I think, while outpatient services are definitely convenient options for our patients, I think we do see a disconnect sometimes in the amount that occurs in the outpatient setting and then what's being documented or getting put into the record. Again, I kind of go back to that documentation piece. So as data quality partners, for example, Q-Centrix is only able to capture the information found in the legal medical record where the primary procedure was actually performed. And that same thing applies if hospitals were selected for audits from national registries like the STS or the NCDR. Therefore, auditors only have access to the EMR. And so it's really in their best interest to have some sort of collaboration mechanism between physicians, facilities, surgeons, et cetera, that's crucial to ensure that the data is transferring and being shared appropriately from outpatient to inpatient and vice versa.
Thank you. Okay. If anyone has additional questions, feel free to submit them. It looks like we probably have time for one or two more. Sarah DeMin, I think this one's well suited for you. As you look to the future of cardiovascular care, what emerging trends or technologies should program leaders prioritize to ensure they stay ahead of changes in CV care delivery, patient expectations, and quality metrics?
I think we've touched on a lot of those today. So there's absolutely a shift into the outpatient market that's anticipated for cardiovascular care in general. So if you're not thinking about it yet, you want to be. It's an opportunity for programs, again, to kind of move some of their stable patients into a different setting as you're collecting the different aspects of that again, the registry, if you're looking at the care, then kind of you're comparing apples to apples. Your stable outpatient population is together, and you can look at your care and your outcomes there. Your more at-risk patients that have a higher chance of having some difficulty in their outcomes, are going to be all within your inpatient population, and you can evaluate the care that you're providing there. So you definitely want to be thinking about that. And then TVT, again, structural heart is there's numerous devices that are still in FDA approval processes and studies. And as they're approved, they're going to potentially open up patient populations for treatment, which is not something we're treating a lot of our population already. There's not a whole lot of new populations upcoming. TVT and structural heart in general is a great opportunity for facilities to kind of take a look at that and be ahead of it and look where that belongs in their program overall, again, 3 to 5 years down the road. As far as technological tools, I think it's really important to identify a tool that is going to give you insights into not only what the registry is going to tell you, but potentially more. And so I think the registry is kind of like the grade book. And do you have insights into why you didn't meet the grade? So look for technological solutions that give you that edge, so that you can begin affecting, again, your reality, cardiovascular excellence, the reimbursement, to make sure that your program is as successful as it can be, not only in outcomes, but in longevity, so that you can continue to provide excellent comprehensive care to your patient population.
Thank you so much, Sarah. That was actually our last question. Thank you to all three of you, Sarah, and Shauna, for your insights during that Q&A portion. I'm sure it's super valuable for everyone. That concludes our webinar for today. Want to take a moment to sincerely thank you all for joining. And please, if you have a moment, complete our quick survey at the end of the webinar to give us your feedback on today's conversation. Thank you all for your time, and we hope you have a great rest of your day.